Dr. Coco. Dr. Aliu.
Yes, Dr. Adeboye, I'm with you.
Over to you, sir. We can start. Dr. Yusuf is here already. We can start, sir.
Okay. Respected senior colleagues and colleagues, welcome to today's webinar. Today, University College Hospital Ibadan will anchor this month's webinar on endoscopy in neurosurgery. Our presenters will have Dr. Cotton and Dr. Adebayo. Each of the presenters has 25 minutes to talk to us on this incredible topic, and we reserve our questions and comments till at the end of the presentation. Speakers from University College Hospital, you are highly welcome. The platform is yours. Thank you.
Thank you very much, sir. Good evening, all. I'm Dr. Kotomepo Igri, a neurosurgical resident at UCH. I'll be presenting the use of endoscopy in neurosurgery using this outline. The word endoscopy is derived from the Greek words endon, meaning inside, and scopy, meaning to see. Endoscopy, therefore, is a procedure in which the interior of a body part is visualized using an endoscope inserted through a natural or created orifice. It's a minimally invasive procedure. Neuroendoscopy is that subspecialty of neurosurgery that deals with the treatment of central nervous system pathologies with an endoscope. The utility of the endoscope has evolved from a solely diagnostic tool over time to embrace therapeutic options as well. Advancements in instrumentation, dissection, and hemostatic techniques, as well as camera technology, have led to the expansion of the application of, as well as neuroendoscopic. The integration of emerging technologies like augmented reality and robotics is poised to revolutionize the field of neuroendoscopy even further. Category neuroendoscopic procedures. Osborne and Lexi, who define the three categories of neuroendoscopic procedures, including pure endoscopic procedures, endoscope-controlled microsurgical procedures, and endoscope-assisted neurosurgical procedures. Pure endoscopic procedures are procedures performed with endoscopic instruments under complete endoscopic visualization. Endoscope-controlled microsurgical procedures are performed using microsurgical instruments under endoscopic visualization. The microscope does not feature in these procedures. Endoscope-assisted procedures are those which combine the advantages of the microscope and those of the endoscope in the same intervention. The microscope provides high-definition, three-dimensional images, but is limited by the fact that the observer can visualize only structures that are situated in the direct line of sight of the scope. This is where the utility of the endoscope becomes apparent. It gives the surgeon a panoramic view of the surgical field and also allows the surgeon to look around corners, as you can see in the second and third images. The history of neuroendoscopy. The first reported neuroendoscopic procedure was performed by Victor Darwin Lespinasse in 1910, who performed bilateral choroid plexus coagulation on 2 hydrocephalic children, using a cystoscope. Unfortunately, one of the children died after the procedure. Mixter in 1923 performed the first endoscopic third ventriculostomy. In 1966, Harold Hopkins designed the now famous Hopkins rod lens system, which replaced the earlier rigid endoscopes that suffered from poor light transmittance and extremely poor image quality. In 1973, Takanori Fukushima introduced the neurofibroscope. Despite these early advances in the field of neuroendoscopy, neuroendoscopy was not popular because of the poor outcome of operated patients. The combination of crude, non-specialized instruments and primitive neuroanesthetic techniques limited the wide acceptance of this minimally invasive approach. The field, however, continued to advance, and in the late 1970s, Dr. Apuzzo introduced the side viewing telescope, which marked a major forward step in endoscope design. In 1986, Jacques Semet designed the first prototype of a new multi-purpose endoscope. This is a picture of the endoscope he designed. It has a round cross-section and a 6 millimeter maximum outer diameter. The endoscope features an eyepiece indicated here, and also has working channels as shown. What are the advantages of neuroendoscopy? Endoscopic procedures are characterized by smaller incisions or entry points when compared with traditional open neurosurgical procedures. This minimizes damage to normal brain tissue and ultimately translates to reduced post-op pain, shorter hospital stay, faster recovery and return to normal activity, as well as cosmetic scars. Furthermore, the high-definition cameras and special optics of the endoscope offer enhanced visualization of the surgical field, which facilitates precise lesion targeting and minimizes damage to adjacent normal brain tissue. Neuroendoscopy has its disadvantages. A surgeon transitioning from traditional open neurosurgical approach to neuroendoscopy faces a steep learning curve. It takes a lot of time and practice for a surgeon to acquire the proficiency and manual dexterity that is required to perform neuroendoscopic procedures seamlessly. Furthermore, endoscopic equipment are expensive, and a small neurosurgical service may not be able to afford them. Additionally, with the advantage of minimal access comes the limitation of a small working space, which limits the range of motion of the surgeon. Also, neuroendoscopes produce two-dimensional images, which constitutes a problem for navigation within the surgical field. The surgeon is compelled to rely on his experience, a good knowledge of anatomy, and also spatial awareness to minimize or avoid damage within the surgical field. The problem of small working space increases the risk of fatigue and discomfort, especially when neuroendoscopic procedures are prolonged. In addition, neuroendoscopy is not suitable for all patients. Careful patient selection is key. And patients with certain complex conditions are better served with traditional open approach. Finally, the integration of emerging technologies in neuroendoscopy would constitute a problem. This is because the surgeon must stay abreast of the latest advances in the field in order not to be relegated to the side. There are two basic classes of neuroendoscopic instruments, the rigid endoscopes and the flexible endoscopes. What is the principle of endoscope operation? The principle of endoscope operation basically follows the science of optics. Light emitted by a source enters and illuminates the surgical field. The returning light is transmitted through an objective lens system and through a relay system, and ultimately a clear focus image is generated. Rigid endoscopes have superior optics compared to the flexible endoscope. However, they are they lack steerability. In order to overcome this problem of lack of steerability, angled endoscopes of various degrees have been introduced, which enable the surgeon to look around corners. These pictures depict the two ends of a rigid endoscope. The first image shows a 2.9 millimeter main working channel for instruments and two 1.6 millimeter side channels. This is a 1.7 millimeter objective rod lens. The second image shows the entrance into the working channels. These are the two entrances into the small working channels, and this is the entrance into the main working channel. The flexible endoscope is more maneuverable, but this increased maneuverability comes at the expense of image quality. The parts of an endoscope. An endoscope comprises a tube, which could be rigid or flexible, depending on whether it's a rigid or a flexible endoscope. It has a light delivery system that transmits light from the light source onto the surgical field. It also features an objective lens that receives and transmits the emerging rays from the surgical field onto a relay system, which in the case of a rigid endoscope consists of an array of rod lenses and could also consist of optical fibers in the case of a flexible endoscope. The endoscope also features an eyepiece lens through which the surgical field, through which the image may be visualized, as well as working channels for insertion of instruments into the surgical field. This image shows an obturator and an endoscope sheath. The obturator is this cylindrical rod, and the endoscope sheath is the hollow. This is the obturator, the cylindrical rod, and this is the endoscope. It's a hollow cylindrical tube that permits insertion of the obturator. Together, the obturator and the endoscope sheath permits atraumatic penetration of the brain and the ventricles. The endoscope sheath also permits insertion of the endoscope after creation of an access. Energy sources for dissection are also available, including monopolar and bipolar coagulators, as well as fiber optic laser. Nd:YAG laser and potassium titanyl phosphate lasers are the most laser types that are used for neuroendoscopy because they can walk through water. There are various neuroendoscopic instruments, including scissors of various types, biopsy and dissecting forceps, surgical microforceps, as well as guillotine knives. The endoscope camera has evolved over the years. Initially, one-chip cameras were used in the 1990s, and these cameras produce poor quality images. However, nowadays, full high-definition 3-chip cameras are in use. These cameras boast 6 times better resolution than standard cameras and produce crystal clear images. The light source could either be a xenon light source or a halogen light source. Xenon light sources because they are more efficient in the sense that greater proportion of the input energy is converted to light. Only a smaller fraction of energy is lost as heat. Also, xenon light is whiter and more closely resembles natural light than does halogen light. Although neuroendoscopy can be done freehand, neuroendoscope holders aid the stabilization of the endoscope and the endoscope sheath when bimanual instrumentation is required. A documentation system for recording of image and video sequences is also a part of the neuroendoscope setup. Image-guided endoscopy. Intraoperative CM fluoroscopy can be used to monitor the position of the endoscope tip at all times. Intraop ultrasound scan can also provide information about the location of the endoscope relative to intracranial structures. And the neuroendoscopy can be done under stereotactic guidance. What are the applications of neuroendoscopy? First, endoscopic transnasal. This approach has redefined the management of pituitary tumors and skull-based lesions and has emerged as the gold standard for pituitary tumor resection. The endoscopic approach via the nasal passages provides an access to anatomical regions that were previously difficult to reach and is associated with minimal surgical complications compared to open surgical approach. Endoscopic ventricular surgery. This approach has transformed the management of hydrocephalus and intraventricular pathologies like intraventricular tumors and colloid cysts. The endoscopic approach to the management of hydrocephalus has minimized the need for conventional shunting procedures. The endoscopic approach has also emerged as a effective treatment for the management of extraventricular cysts. Endoscopic penetration of arachnoid cysts in the sylvian fissure or interhemispheric fissure has expanded the treatment options for the management of this condition. Endoscopic spinal surgery. This approach has emerged as a minimally invasive alternative to open neurosurgical approaches for the management of disc herniation and spinal herniation, and confer advantages of reduced post-op pain, shorter hospital stay, and faster patient recovery for treated patients, as well as cosmetic surgical scans. The integration of the endoscopic approach into vascular neurosurgery has emerged as a minimally invasive alternative to traditional open surgery. It has been used in endovascular coiling and aneurysm clipping. Endoscopic visualization aids with detailed visualization of vascular structures and minimizes complications. What are the recommendations to reduce complications of neuroendoscopy? It's advised that the surgeon should play video games. This is because playing of video games improves eye-hand coordination, which is an essential skill for neuroendoscopy. The surgeon should also avoid making quick movements when the instrument is in the vicinity of the target lesion in order not to damage normal tissue or to prematurely rupture a vessel or the lesion itself. It's also advised that 2 sets of each endoscopic equipment or instrument should be made available for obvious reasons. If one equipment fails,
sorry, sir, Dr. Barry just he was trying to do.
If one equipment or instrument fails, a backup can be used in its place. The surgeon should always confirm the correct function of each component prior to surgery. It is prudent that the surgeon should learn from the mistakes of others and avoid repeating sin. The surgeon should also dedicate time and effort to performing anatomical dissections and attending hands-on workshops to strengthen his hands. What are the challenges of neuroendoscopy in Nigeria? In addition to the well-known disadvantages of neuroendoscopy earlier outlined, there are challenges that are specific to practice in a poor resource setting like ours. These challenges include patient factors like financial constraints and negative beliefs regarding the safety of neuroendoscopy. Hardware failure as a result of frequent power outages, poor handling, and storage of neuroendoscopic equipment is also a problem. Additionally, poor endoscopy support infrastructure is a significant problem of neuroendoscopy practice in Nigeria. Future perspectives. It's envisaged that neuroendoscopy will benefit from further technological advances in camera and optical systems design, from innovations in surgical instruments design, as well as from integration of navigational and robotics systems. Newer technological advances like multi-port endoscopy, surgery integration will also lead to advancements in neuroendoscopy, as well as advancements in telemanipulated neurosurgery. In conclusion, neuroendoscopy has emerged as a minimally invasive alternative to traditional open neurosurgery. Careful patient selection is key to success. Neuroendoscopic surgery is expected to become a routine part of neurosurgical practice in the future, and hence, training institutions should develop training programs for young neurosurgeons. These are my references. Thank you very much.
Thank you, Dr. Cotton, for this excellent presentation. So the next presenter, Dr. Adebayo, can you go ahead, please?
Good afternoon once again. I'm Adebayo Adebayo, Senior Registrar in Neurosurgery in the University College Hospital, Ibadan, Nigeria. We're taking the transsphenoidal pituitary surgery, the surgical steps and the complications. We're following the listed outline. Transsphenoidal pituitary surgery is a minimal invasive procedure used to remove tumors, lesions in the cellular or the paracellular region. Traditionally, the approach can be done via three major routes. You can go through the nose, that's the endonasally. You can go through the transseptal route or the translabial route. It can be done with the use of an operative microscope, or it can also be done endoscopically. Endoscopic endonasal transsphenoidal surgery has become a major gold standard in the resection of pituitary tumors. And it is well known for the excellent visualization and the role of minimal tissue invasion that it plays in patient management. The list above just shows a brief historical background of the procedure. Jules Hardy, who classified the parastellar extension of the pituitary tumor, introduced the operative microscope and developed fluoroscopy in 1969. And Ricardo Curell in 1977 reported the largest series of patients who had undergone endoscopic endonasal pituitary surgery. The approach has been modified over the years by surgeons, and Considering a preoperative consideration, it is important to note a very good patient selection. Not all patients will be ideal for the approach. So as a surgeon, it is paramount that one selects the patient carefully. The size of the nose and the nostril is also important in considering this approach. Presence of the septal deviation and perforation, especially in patients with that wears a nose ring, are very important. Past history of septal surgery, degree of pneumatization of the sinus, especially the sphenoid sinus, is also very important. This can be noted through studying of the preoperative neuroimaging, especially the CT scan and the MRI. There is history of sinus disease in the past or even presently. That's a contraindication to such procedure. Indications include pituitary tumors, right cyst, arachnoid cyst, craniopharyngiomas, and also CSF leaks. The goal of surgery is actually to relieve the mass effect of this tumor on the surrounding structure, especially the visual apparatus. And also sometimes it could it could be as large enough to cause obstructive hydrocephalus. Also surgery can be used to normalize excess hormonal production, which is from if you have a highly secreting tumor. Also to preserve and restore normal pituitary function, histological diagnosis, and also in research wise, this can be done as well. A thorough knowledge of the surgical anatomy of the routes through which the surgeon will transit before getting to the lesion, the sellar region, is very important to be able to carry out this surgery with success. Nasal cavity anatomy, sphenoid sinus anatomy, the sellar, testicle, and the pituitary gland anatomy itself. The picture above just show a sagittal view of the nose. This is the nasal cavity, and this is the sphenoid sinus. This is the sellar with the pituitary gland in it. This is the anterior. This forms the anterior scorbus, and the routes through which the surgeon transits through, which before he gets to the sellar, is as outlined. This is an endoscopic view of the nasal cavity. The picture to my left shows the nasal cavity, the nasal septum. You have the inferior turbinate, the middle turbinate, the floor of the nasal cavity. The concha is interiorly located, and then these landmarks are actually very important to recognize when one is carrying out this approach. The surgical anatomy of the sphenoid sinus, it is paramount to consider that there are variations in the sizes and the degree of pneumatization and also number or degree of septation in the sphenoid sinus. This will help to plan the surgery properly and avoid complication. The images shows the various CT scan of various types of sphenoid sinus that are present. The top panel shows the types of the coronal, the sagittal view of the types of the sphenoid sinus. The middle panel shows the coronal view, displaying the lateral pneumatization and the location and the orientation of this septum. It has been reported that there are about 3 or 4 categories of sphenoid sinus according to the degree of pneumatization. They could be the conchal type, the presellar type, the incomplete sellar type, and the complete sellar type. The majority, 75% of the population has a complete sellar type. And this has a major role to play in planning the surgery, especially when it comes to the sphenoid phase of the endoscopic transsphenoidal surgery. Instruments have been spoken about earlier on. I will not waste much of our time. Yeah, this represents an endoscopic gantry that one will need for the surgery. You have the monitor, you have the lights, you have the light source, you have the light cable, you have the camera head, We have the cameral compartment, and there are various, the commonly used endoscopes with varying viewing angles. You have the 0 degrees, 30 degrees, and the 45 degrees endoscope. Also, one needs to be conversant with surgical instruments as well. As earlier stated, the transsphenoidal approach can be done endoscopically or can be done using a microscope, but one can combine the two. Or we'll have the endoscopically assisted microsurgery, transsphenoidal microsurgery. The targets of the endoscopic endonasal transsphenoidal surgery is outlined in the picture of the skull base displayed above. The yellow area shows where the area of surgery where one can use the approach from the cribriform plates, anterior cranial fossa planum, sphenoidally to the sella, and also down as far as the clivus. The orientation of the scope will depend on the approach or the target area where the lesion is located. A good preoperative setup will afford the surgeon the maximum tumor exposure and also maintain the good surgeon ergonomic comfort and spatial orientation to make the surgeon comfortable. This picture displays a typical theater setup when about to carry out an endoscopic endonasal transsphenoidal surgery. It actually could be done by a surgeon, or you can use two surgeons can be involved: the ENT surgeon and the neurosurgeon, the scrub nurse or the scrub technician, the monitors facing the surgeon, the anesthetist to the left side and the foot of the bed, as displayed above. The arrangement of the operating table is such that it assumes what they call the lawn chair position. The torso is elevated about 20 to 30 degrees to the horizontal. The neck of the patient is tilted to the left, and the head is turned about 10 degrees towards the surgeon and fixed on a Mayfield held holder. The degree of inclination of the head actually depends on the extent and location of the lesion. The anatomic midline of the patient should be parallel to the wall of the operating room. Neuro navigations could be very, very helpful, and this could increase precision and accuracy, especially in the cases of recurrent surgeries or cases in which you have extensive paracellar extension of the lesion. This picture shows a typical arrangement as shown, how the patient is positioned. The nasal dosum is parallel to the floor. The head of the patient is tilted towards the left. The surgeon, the assistant standing towards the right of the patient, the scrub nurse, and all that. This imaging intensifier is used when you want to use a microscopic method. This is not needed a endoscopic approach. The patient preparation of the patient starts by doing nasal decongestion. There are various nasal agents that are used. In my center, we use xyloacinol spray, and this helps to reduce the congestion of the nose. However, it is important to note that this is contraindicated in patients with a history of hypertension and coronary heart disease. This can worsen their status. Intranasal anesthesia can be done by use of platelet soaked in 1% lidocaine and 1 in 200. Some people use 1 in 100,000 epinephrine, placed in between the middle turbinate and the nasal septum, just 5 to 10 minutes before the surgery. The nurse is swapped with antibiotics, impregnated swab. The face and the nose is prepared with antibiotic impregnated solutions, and also painted with iodine. The use of tranexamic acid has also been employed to reduce risk of bleeding. The attention needs to be noted in patients with pre-op adrenal insufficiency. Such patients are given stress dose hydrocortisone, except for patients in case of Cushing's disease. Anesthetic concentration, especially in patients with acromegaly, is very important. because such patients have risk of difficult airway and also have accompanying multisystemic disease that needs to be looked into and optimized appropriately before surgery. The patients need to be planned for and prepared for skull-based reconstruction, or in anticipated CSF leak. And after positioning the patient, the area of the body, the subumbilical or the lower quadrant of the abdominal side is prepared. Also, the lateral side can be prepared. These are sites where one can harvest fat or fascia or tissue for stellar floor reconstruction. This procedure is divided into the above mentioned phases: the nasal phase, the sphenoidal phase, stellar phase, and the stellar floor reconstruction. In the nasal phase, the goal is actually to reach the sphenoid ostia and also do a posterior nasal septectomy. The endoscope one could use a 0-degree endoscope with 4 millimeter in diameter and 18 millimeter long. Landmarks are to be noted for orientation, for proper orientation, so that one will not miss one's way. The ideal is to keep to the midline so that you don't injure vital structures that are nearby. The first step after identification of the landmarks is lateralization of the middle or inferior turbinates to allow for more room and maneuverability of the instruments within the nasal cavity. Some surgeons prefer to do a turbinectomy, and this is in anticipation for the turbinates that has been removed will be used for future stellar reconstruction when the surgery is being completed. Identification of the sphenoid ostium, it is said that it is located about 1.5 centimeters above the root of the concha. However, the surgeon needs to note that there can be variation in the location of the sphenoid ostium, especially depending on the degree of pneumatization of the sphenoid sinus. The picture above shows the endoscopic view of the nasal cavity, the nasal septum, the middle turbinates, the retropharynx, and the eustachian tube. This is the sphenoid ostium at the posterior end of the nasal septum, and then adequate anesthesia and hypotensive anesthesia is needed for clear operative field. The nasoseptal flap, it was first described by Haddad et al. In 2006 in a case series that was reported. The flap is based on the diffusion of the posterior blood supply from the posterior septal branch of the sphenopalatine artery. Vasoconstrictive agents, about 1% lidocaine with adrenaline, with or without 1 in 200,000 epinephrine is used. The size and method of harvest is dependent on the anticipated skull base defects. And after harvest, the flap is tucked into the nasopharynx or the maxillary sinus. This picture shows the orientation of the incision that is made. One care should be taken not to go beyond 1 centimeter from the nasal box. This is to protect the olfactory mucosa, so that patients will not lose the sense of smell after surgery. And after the harvest of the flap, the flap is tucked into the nasopharynx. In children with endonasal, the endonasal cavity is accessed through the sublabial incision, especially because they have small nasal cavity or they have small or developing nas. Also, in patients with smaller nasal cavity or developing, the sublabial incision route is employed. In the sphenoid phase, the surface of the pneumatized sphenoid sinus is entered after the posterior septectomy of the nasal septum is done to create more room, and the sphenoid ostium is identified, and the sphenoid ostium is identified the sphenoid, the rostrum is identified, and the widening of the sphenoid ostium is done from one end to another. This is also to take to remove the anterior wall, or the anterior wall of the sphenoid sinus, known as the anterior sphenoidectomy, is done. About 20% of the patients with septation, we should note that sphenoid septum that are laterally located has a close relation with the cavernous carotid protuberance, which is where the intracavernous carotid artery is located, and care needs to be taken so that the structure is not damaged. This picture shows the after the removal of the anterior sphenoid wall, and then the removal of the sphenoid septum. This is the sphenoid sinuses on both sides that are being viewed. After the removal of the sphenoids, after the entering of the sphenoid sinus, then the anatomy of the structures and the landmarks in the sphenoid sinus needs to be noted so that it will guide one to in where to go, appropriately entering into the sella. This is where the sphenoid floor, the sellar floor is located. And anterior to that, you have the tuberculum celli and you have the planum celli. To about 2 o'clock, you have the optic protuberance, which is where the optic canal is located, through which the optic nerve passes through. The optical carotid recess is the space in between the optic protuberance and the carotid protuberance, which is where the carotid intracavernous carotid artery is located. This is the clivoid, clivois, located as a clivoid depression. The sellar face include opening of the sellar floor, removal of the lesions, and reconstruction of the sellar floor. The sellar floor might be thinned out in most cases, especially when the patient has large tumors due to chronic remodeling. And in cases where the sellar floor is not thinned out, especially in patients with small tumors, one needs to be careful. Initial opening after verification of the midline is made with either drill or hook, and the boning window is widened with kerosene punch, and to reach the planum above, and the sellar floor below. Below. Before opening of the dura, one needs to pay attention because the inferior and superior intercavernous sinus is there. In patients with bigger tumors, this would have been compressed, so the risk of bleeding is reduced in them. However, patients with smaller tumors, one needs to pay attention to that because this could actually come off as the initial bleeding when entering into the sellar floor. And ordinary using of bipolar to arrest the bleeder, or using of sellar clips can help to reduce bleeding so that one can have a good operating field. The picture above shows the way the sellar floor is being removed. This is kerosene punch trying to chip off the sellar floor and exposing the sellar. Opening of the sellar dura is of various methods. People have used use of circular incision or square incision, especially when it is suspected that the tissue is the tumor would have invaded the sellar dura. This can afford the opportunity of sending the dura also for histological diagnosis. So other surgeons have employed the use of a cruciate incision, either diagonally or in the crucifix form. And attention is paid. Attention must be careful not to go too lateral so that one does not injure vital structures that are laterally located. After durotomy, the sellar floor is explored, and the pituitary adenoma tends to be, in pituitary adenomas, the normal pituitary gland tends to be displayed posteriorly, while in right case pouch or in right case cleft cyst, it is tend to be displayed normally anteriorly. This picture shows a durotomy being done in a cruciate manner and entering into the sellar. Removal of the lesion of the cellular tumor is best done in sequential order. Inferior portion is removed first, followed by the lateral portion. Actually, it's actually described as removing the floor and then removing of the wall of the building before the roofs, so that the roof can come down. So when the floor or the inferior portion of the tumor is removed and the lateral portion of the tumor is removed, it is expected that the superior aspect of the tumor will descend into the cellar, and this will be within the reach of the surgeon. The risk of diabetes insipidus is reduced when careful dissection is done. In some cases, the superior, the tumor could have some supracellular extension, and such part of the tumor will not descend into the cellar. So there are some maneuvers that have been employed to ensure the supracellular portion of the tumor is descends into the cellar cavity. The Valsalva maneuver, or compression of the jugular vein compression, or injection of about 2 to 3 mils of normal saline through the lumbar drain after the removal of the same amount of CS step through the lumbar drain has also been found to be helpful. Reconstruction of the cellar floor includes has been done via various methods. People have used fat. People have used intradural packing of the cellar, and also packing of the sphenoid. People have used the turbinates that was previously harvested in this nasal phase, and also in the face of CSF leak, one can use a nasoseptal flap. It has also been reported the use of synthetic or bioresorbable materials also have been employed in the repair of the cellar floor. The goal of cellar floor repair is to afford protective barrier against the exterior, reduce dead space, and also prevent the descent of the optic chiasm into the nasal cavity. One should avoid overpacking the cellar so that one will not cause pressure on the optic chiasm and cause postoperative worsening of visual or the vision. Well, after the surgery, adequate hemostasis is secured. Final revision is done just to be sure that all bleeding points are arrested. And if the turbinate was lateralized, it is gently returned back to its anatomical position, and care must be taken so that it doesn't cause post-op synecdoche. Post-op care of patients, such patients are managed ideally in HDU or ICU. Patient is maintained in head-up position. Close neurovital signs monitoring, fluid intake, output monitoring is very important. Serum urinalysis, serum electrolytes, and osmolality monitoring is important. The post-op hormone profile, because some of them come down with hypopituitarism, post-op hypopituitarism, and these need to be taken care of as urgent as possible. Post-op visual acuity test, and then nasal care to prevent nasal crust is also very important. Post-op neuroimaging to assess if there is any post-op bleed, tumor bed, and also extent of resection is done. This is the list of the complications that have been attributed to transsphenoidal, endoscopic transsphenoidal surgery. Thank you.
Thank you, Dr. Adubayo, for this beautiful presentation. Now, comments and questions from our listeners. Comment and questions, please, for the two presenters. Well, it appears nobody has questions and comments for our speakers because nobody is raising his hand. Once again, welcome everyone for this month webinar. Our faculty, Dr. Yusuf Salman, a respected neurosurgeon, consultant neurosurgeon at National Hospital Abuja, and head of neurosurgery. He's also senior lecturer with University of Abuja. Sir, we'd like to have your contribution to today's presentation. You're welcome, sir.
Okay, good evening, everyone. I would just like to say that it's been a very good presentation on endoscopy in neurosurgery. And I must commend the two presenters for doing justice. I will do my comments in two ways. The mode of slide preparation and delivery. I just want to say for future presentation and even international audience, it's supposed to be a PowerPoint presentation. Sometimes the slides are too crowded. Not all the slides. Towards the end, we have very good presenters, especially the first presenter. So we need to work on the format of our slide preparation. The content have been very nice and very good. All the scope. Traditionally, neurosurgeons are trained with microscope, and the evolution of endoscope has been presented. Actually, it's a borrowed technique from our ENTs colleagues, basically, especially the endonasal approach. And in some centers, the procedure is done in conjunction with the ENT surgeon. My advice to young neurosurgeons is that you should master all the steps of the endoscopy transsphenoidal surgery so that you are not dependent on the ENT surgeon. So you should be able to master all the steps. And it's a very straightforward procedure to do transsphenoidal surgery. The presenter has done justice to that. Let me just say the nasal phase, what you need to pay attention to is the turbulences, the septum. And it's important to lateralize the middle, even the inferior turbinate and then the middle turbinate. By the time you do that and the middle turbinate, your sphenoid ostium is in your view. However, I must say that it is not compulsory to see the ostium to be able to do a transsphenoidal surgery. By the time you pay attention to the middle turbinate, and that can be a guide for you. And that is why for neurosurgeon, we don't do a turbinectomy routinely. The others serve as a map. And for starter, I will advise that you try to master binostry approach because it gives you a wider manipulation for your endoscopes. Now, most of us may not have the luxury of having an endoscopy order, but if you have that, it helps. Otherwise, you need a good assistant to be able to do a comfort. Sometimes the procedure can be very nauseating if your assistant is not well tutored. Hazards are to the side, so we should maintain midline orientation. All the hazards are basically to the side, the carotid, the cavernous sinus, even the cranial nerve in the cavernous sinus. So we should maintain a midline orientation all the time. Most of the time, we don't need a CHAM, but for some cases, we may need a neuronavigator guidance. Intraoperative ultrasound, again, it's a good adjunct, but it should not deter you. So you should not say, because I don't have this, I will not do the procedure. No. You can do a good transsphenoidal surgery without even the ultrasound. So in the center where it's available, people use neuronavigator. That's luxury. If you don't have, I think you should just go ahead. And they has given all the steps. If you are using the 2D endoscope that we use commonly, then we'll do the step in the order he has presented to, first of all, remove the inferior part, lateral part. Because if you remove the superior part, your diaphragm will descend and you'll not be able to do anything further. I'm not too sure. I think in between, I missed some of this, but I'm not too sure that the presenter emphasized the use of a lumbar drain. If it does, that's fine. If you are operating on a big tumor, it is important to put a lumbar drain. Your lumbar drain serves one basic purpose. After your initial decompression, then you will ask your anesthetist to infuse a saline through the lumbar drain to bring down the tumor so that you can do a further decompression. Again, in the adventure that you have a CSF leak, then you already have a lumbar drain that you keep open for some time post-operatively, and that one will help you. One advantage of endoscopy is that you can do the procedure without putting nasal pack post-operatively. So even though many of us still use the nasal pack, but if you have done a proper dissection for an endoscopy transsphenoidal surgery, you don't need a nasal pack. And that is actually an advantage over the microscopic approach. It is important for us, they have said, to learn this procedure. It is easier to set up an endoscopy practice in our own environment because other subspecialties also like they also use endoscope. So we can have one single endoscopy gallery for more than one specialty, not that is dedicated to neurosurgeon. So in center where you don't have a microscope or you don't have the appropriate microscope, so you can always use endoscope in conjunction with orthopedic surgeon that do arthroscopy, the urologist for urethral resection of prostate, and even other than ENT. So don't be afraid to collaborate with other people and try to get training and watch video and then learn from the expert. I think by and large, it's been a very good session. Thank you for inviting me to be part of this presentation. Welcome.
Thank you very much, sir, for this excellent summary and talk on neuroendoscopy.
Thank you.
Thank you, our respected teachers and senior colleagues, and international. Our seniors, our teachers, any comments? We would like to recognize the presence of our boss, Prof. Nasiru Jinjiri Ismail. Also, Dr. James Balogun. SARS, any comment, any contribution on this topic,
Hello.
SARS?
Hello.
Yes, sir.
Hello, can you hear me?
Yes, sir.
Yes, it's a very good presentation, and we all know that, like Dr. Salman mentioned, that is very easy to start an endoscopic procedure in many centers because urologists and general surgeons and the ENT usually have the tower, the light source and other facility. All you need are your scopes, instruments. So that really reduces the cost for the setup and for endoscopic neurosurgery. Second is the issue of fogging of the lens. There are many lens modification now with self-irrigating lens. So you have to probably find a way to be clearing your lens, especially if you encounter some bleeding during the endoscopic nasal transsphenoidal surgery. Another thing to be aware of is the Onodi cells. Sometimes the ethmoidal cells extend really backwards up to the anterior clinoid. And like they said, sometimes if you are not sure, you can still use the C-arm to actually find your way, even if you are using the endoscope. Because sometimes, especially if you are drilling and you enter a multiseptated sphenoid sinus and you tilted your scope slightly cranial, you may end up in the Onodi cells. And after the Onodi cells, usually one can get to the optic chiasma. The Onodi cells are important, especially for extended transsphenoidal surgery. If you are doing the racket cleft cyst, craniopharyngiomas, that sometimes extends. You can use the Onodi cells to locate where you are, drill them, and extend to remove further tumor. And especially if you are dealing with the cellular meningiomas going through the transsphenoidal sinus. For the lumbar surgeries, usually they have a self-irrigating system. You have to be careful about the self-irrigating system. It has a pressure. You want to go slightly above the venous pressure. If you go much higher than the venous pressure to the arterial pressure, you can start having intravasation of blood vessels during your lumbar endoscopic surgery. So you have to really control the irrigation pressure, especially when you're doing an endoscopic lumbar surgery. Most especially if it is around the cervical area. If you have of that fluid around the cervical area, you may have some congestion, raised ICP. Yes, so this is a very good presentation. We wish you all the best. Thank you.
Thank you very much, sir, for your contribution, sir. Yes, sir. Dr. James Balogun, sir. Any contribution for us?
All right. Good afternoon, everyone, or good evening, everyone. It's a pleasure to be here, and obviously, the presenters are from my center, so a little bit like, okay, let me just sit back and also enjoy contributions from other people. Obviously, it's the comments from Dr. Yusuf and Professor Nasser are very valid. I think my suggestion to the young neurosurgeons would be the fact that in trying to start up this kind of practice, I think really paying attention to developing yourself, particularly understanding the anatomy of it, is really, really important. I think understanding the anatomy of the nasal cavity, which is not the usual neurosurgeon stuff, is really important. And I mean, you could say I'm far-fetched, but I would usually recommend some form of cadaveric dissections prior to full clinical practice, because cadaveric dissections would give you the opportunity to really explore what you think you can injure, what you cannot injure. I think where we are at variance with the ENT surgeons really with this procedure is the fact that the neurosurgeons barely pay attention to the quality of life that is impacted by the amount of work we do transnasal. Dr. Adebayo mentioned that it's a minimally invasive approach. I usually disagree to say that, yes, the approach gives us direct access, but the amount of work sometimes that you do intranasally isn't really minimal. Again, when you pay attention to the anatomy and understanding some of the details, it also gives you an opportunity to really be able to adopt your practice. And there are many nuances of, fortunately for endoscopic practice. For example, he mentioned, and Dr. Yusuf mentioned lateralizing. In my practice, I usually resect the middle turbinates. And that resection also helps me in terms of trying to reconstruct the sellar floor. Again, depending on the kind of tumor you have, it all depends on whether you're raising a flap or you're not raising a flap. Again, the use of lumbar drain, I think, again, is also personal. It also depends on how much your anesthesia team is also familiar with the procedure. I do a lot of salva maneuver within the surgery, within the operation, in order to be able to get tumors down and all that. So again, it depends. I think while Dr. Yusuf mentioned the fact that, yes, we should know all of what it entails, when you do have a tumor that is actually vascular, sometimes it's very challenging for one surgeon to handle, especially even if you're doing a binostril approach, because when the tumor is coming out and it's vascular or it's hemorrhagic, to really get control of what you're doing and not wanting to really go just straight on superiorly to get the tumor down and have a narrow cavity through the tumor, and then the diaphragma descent sometimes can be challenging. But of course, if you have a minimal or moderately hemorrhagic tumor that's just coming as you're doing it, it's really pleasant to do without even an ENT surgeon. So again, I'll come back to the fact that I think familiarity with the anatomy, really knowing the deals of the anatomy, whether you see the sphenoid ostium at the end, at the start or not, how do you then locate the sphenoid sinus? Like Professor Nasri talked about, how do you not go through the anterior skull base? In fact, I've seen somebody drill transclival, is actually drilling the clivus. And then I said, no. Why don't you pay attention to this bone is thick? Can't you see that what you're doing? Because once you tilt the scope up, down, away from the cell, you can act, especially in tumors that are not big, that haven't expanded the sellar floor or thinned it out and expanded it. It just sometimes can be confusing. So I think that, again, the learning curve, like this mentioned, is steep. And I usually say that even for those who are practicing and have practiced for years, they should be careful of what we usually call a second learning curve, where now you're very familiar with this procedure, but then you want to be more aggressive. And then in that, be more aggressive, then you go back again to the same complications that you have gone above in terms of trying to go over the first learning curve. For me, it's drilling. I think it's something that we could generally adapt. People should start off. We say there's a gradient to endoscopic approaches. Start minimally with some small tumors. Again, doing a subtotal resection as opposed to gross total, near total resection for large tumors is also valid. Again, try to look at the MRIs to be familiar with whether they go into the cavernous sinus and whether you want to leave them or you don't want to go after them. I think those are key vital issues as you start and as you proceed. Some of the giant tumors that we deal with in our environment that go suprasellar, particularly when there's challenge with CSF leak, do you have all it will take to actually get that CSF leak controlled, whether intraoperatively or postoperatively? I think those are the challenges that we need to pay attention to as we build our practice. But I tell people, build small, start small. Everybody starts small. Don't go after the big ones. Go after the moderate size one that even if you get a subtotal resection, as long as you decompress the optic chiasm for the patient, patient's vision is better. Try to keep the pituitary function as normal as possible. I think you have won. And then you can progressively go further and further and further. The only thing is you need to be true with the patient in terms of follow-up if you do a subtotal resection. And somebody asked a question to say that, do you do a post-op hormone profile? Generally, doing an immediate thyroid, either T4, and then a cortisol AM second morning of surgery, or the second day POD2, just to be sure that, especially in those patients who are hypopit before surgery, I think it's also important, and you can do that easily. And then whether you do a post-op imaging immediately is also another issue that you can actually individualize. I thank you, and it's been a great time being here. Thank you, everyone.
Thank you very much, sir, for this excellent talk. We once again thank everyone for joining this webinar. As we have heard from our teachers and our speakers from University College Hospital on this very important topic in our neurosurgical practice, the advantages of neuroendoscopy are too numerous to mention. As we all know, it minimizes damage to the brain, neuroinflammation, and of course, if done properly, it improves the outcome of our patients. There's some piece that one is expected to pay attention to for any case one is planning to offer endoscopic approach: patient selection. So we should be able to evaluate our patient properly and select patients who will benefit from this procedure. And we also, as surgeons, we should be patient in a macro dissection. You don't have that liberty of being in haste or what have you, because of high risks of injuring adjacent structures. Then we should also be proficient in both endoscopic and transcranial. It is a common saying amongst endoscopic surgeons that there shouldn't be boundaries to define neurosurgeon as neuroendoscopic or open skull base. Pathology must dictate the route of access, whether endoscopic or open. And finally, we should know when to pause. We should know when to stop what we're doing for patient survival, for patient better outcome. Finally, I would like to appeal to our teachers with experience in neuroendoscopy to organize hands-on training for us young neurosurgeons, so that since now we have the theoretical aspects, we should also be given the opportunity to have hands-on, so that we'll get this knowledge and put it into practice. Thank you very much for joining this webinar. I would like to call on Dr. Adegboya to conclude this meeting. Thank you once again.
Thank you very much, Dr. Aliyu Koko. On the behalf of Young Nigerian Neurosurgeon Forum executives and webinar committee, I'd like to thank our trainers, Dr. Yusuf, Professor Nasir, and Dr. Balogun for putting our feet on this pathway game tonight. Also, there are some international participants that I saw during the presentation. Some had left, like Dr. Kabulo and some other participants outside Nigeria. We'd like to thank everyone. Also, the presenters from University College Hospital Ibadan, Dr. Adebayo and his partner. We thank you very much for anchoring today's outing excellently. As Dr. Aliyu Koko has said, our trainers are putting our feet on this pathway. We would like to plead with them, maybe through collaboration and all of that, for the practical aspects as time goes on. The Young Nigerian Neurosurgeon Forum, we always be calling on them, both theoretically and practically, to assist us to guide us further. I thank everyone. Next month is another time, 27th of September. We'll be having a topic, very important topic that all of us, if not all of us, will have something to do with at a point in time. Cervical spondylotic myelopathy. I'll be having one of our fathers in neurosurgery, Professor Mizwe, to be our faculty for that day. So on this note, I thank you everyone for sparing these 75, 80, 90 minutes to be part of this program tonight. The chairman is unable to attend this program, Dr. Guga, because of another engagement elsewhere. So he sent his appreciation to our fathers and to every participant of this evening program. Thank you very much.